Welcome, friends, to the Parkland Institute's 24th Annual Conference, After the Contagion. My name is Mike Parker, and I'm a board member of the Parkland Institute, and I am privileged to be the president of HSAA. We're very pleased to have hundreds of people joining us this evening across Alberta and across this country. I want to start by thanking all of our conference sponsors who have allowed us to keep the cost of this conference very inexpensive. And they are the Alberta Federation of Labor, the Alberta Public Interest Research Group, Athabasca University Faculty of Humanities and Social Sciences, the Canadian Union of Public Employees, Civic Service Union Local 52, the Non-Academic Staff Association, or NASA, at the U of A, the United Nurses of Alberta, the University of Alberta's Faculty of Arts, Woodworth Irvine Socialist Fellowship Endowment, and my union, the Health Sciences Association of Alberta, is also proud to sponsor this conference with a special contribution that allows our keynote talks to be edited and posted to the Parkland Institute's YouTube channel. I also want to thank our media sponsors for helping when promoting our conference. And that would be Alberta View Magazine and CJSR Radio in Edmonton. And thanks to all of you who as individuals contribute to the work of the Institute. Parkland depends on the support of our individual donors and our contributing organizations and unions to fund Parkland's research and education programs. We know and appreciate that many of you already support Parkland, but we are asking all of you to consider making a special contribution or to become a regular monthly contributor. With all that is going on in this province, we need a strong Parkland Institute now more than ever. My friends, a few technical logistics for this evening. We have set up the Zoom chat features so that participants can make comments to other attendees. Please note that neither I nor Dr. Martin will be following in the chat, but we do have staff that will be monitoring, and it makes sure that people are being respectful and adding any links that you might want to follow for information. If you'd like to join in the conversation on Twitter, please use the conference hashtag ParkConf, hashtag PARKCONF. Following Danielle's keynote tonight, we'll be opening things up for questions from our conference participants. If you hover your mouse over the screen, you will see a Q&A button. And this is where you can write your questions. Please make them as succinct as possible. There are also features where you can promote questions that you think are particularly interesting or similar to the questions that you would like to ask. Before I introduce Dr. Martin, we will start this evening with a treaty and land acknowledgement. In recognition of where we are, I'd like to acknowledge that the city of Edmonton is on Treaty 6 territory, of which the city and its citizens have enjoyed the benefits of treaty. We acknowledge and honor our ancestors, traditions, and spirits of this gathering place that the first through Indigenous peoples, the Cree, Nakota, Dene, Blackfoot, Métis, and then the settlers to this special place. We acknowledge the spirit of the ancient and great gathering places in our river valley and in the heart of our city, that has for thousands of years been a peaceful and spiritual gathering place for trade, ceremony, and celebration. We acknowledge the tradition of trade and commerce that drew settlers here and enabled the forging of relationships that saw the creation of Treaty 6. The province of Alberta, and the city of Edmonton. And we acknowledge and honor that we still reside on Treaty 6 territory together, call upon those honored traditions and the spirit and intent of treaty to maintain us in a stronger and lasting relationship. Now, my friends, Danielle Martin is the Executive Vice President and Chief Medical Executive of the Women's College Hospital, or WCH, where she is also a practicing family physician. Danielle is leading the hospital's strategy to establish a women's virtual, Canadian-first virtual hospital aimed at improving care and reducing health systems costs in a way that can be scaled up across our healthcare system. Danielle's policy, clinical and academic expertise, combined with her commitment to health equity, have made her a highly regarded health systems leader. She regularly provides expertise and formal advice to lawmakers, both nationally and abroad. Danielle holds a Master of Public Policy from the School of Public Policy and Governance at the University of Toronto. She's an active scholar and an internationally recognized researcher on health systems issues. As a well-recognized media spokesperson, Danielle frequently provides commentary on health issues through her work at the Health Contributor at the CBC. Her national best-selling book, Better Now, 6 Big Ideas to Improve Health for All Canadians, and it was released in 2017. In conjunction with her work at WCH, Danielle is an associate professor at the University of Toronto, the recipient of many awards and accolades. And in 2019, she became the youngest physician ever to receive the FNG Star Award, the highest honor available to Canadian Medical Associate members. Welcome, Danielle.
Thanks so much, Mike, and thanks to the Parkland Institute for inviting me, and to all of you for taking time out of your busy days to spend some time together this evening. I was reflecting on our time together tonight and feeling a little badly earlier because I feel as though it's been all COVID all the time for all of us across Canada and indeed all around the world. I worried that perhaps I wasn't going to be bringing anything new to your days or to your evenings, but I think that part of the purpose, part of the way that we can find purpose in difficult times such as these is to take a step out of the weeds and ask ourselves what we're learning from this experience that we're all collectively living through. And so what I'd like to try to do this evening is to challenge what we have been talking about as though it were news, to reflect on the many elements of what we see splashed across our headlines every day that in fact isn't news, shouldn't be news to us. And it is in fact just are in fact just new ways of articulating things that we have long known about our health and social systems in Canada. And then I think most importantly, to finish on a note of hope, because I do think that there is some news in this pandemic for all of us, and it relates to what is within our control to do something about. And I know that many of you who are participating in this evening's lecture, like me, are out there participating in daily patient care activities, in the essential work in all of its forms in our healthcare systems and beyond. And I just want to honor all those of you who are participating in that frontline care during these difficult times. Having acknowledged land, the other important thing always to acknowledge is our colleagues. And I want to acknowledge my friend and colleague, Dr. Nadine Caron, an inspiration in my career and a colleague who is one of Canada's only Indigenous women surgeons who works in Northern British Columbia, and with whom I had the honor of collaborating recently on some work that has led to some of the insights that we're talking about this evening. Thank you to Dr. Caron. As I step back and think about what we prepared for as we saw this pandemic, this plague heading towards Canada and towards Canada's health systems, knowing that we were already beginning with some of the highest bed occupancy rates in the developed world, knowing that we didn't have a lot of space to spare in our emergency departments and our indeed in many cases in our hospital hallways, knowing that we didn't have a whole lot of extra staff, very high ratios of nurses and other healthcare workers to residents in our long-term care facilities. And what we prepared for, and in many cases prepared for actually quite effectively, was a particular kind of tragedy. We prepared for what we were seeing in the news coming out of Northern Italy and then coming out of New York, the Armageddon scenario of healthcare workers falling ill, people working 30-hour shifts, not enough beds to put patients into, and horrible choices having to be made about who was going to get the ventilator. And of course, we had to prepare for that particular tragedy. So far, thank goodness, we haven't seen tragedy at that particular 12 out of 10 volume level in Canada's health systems. But in rushing to prepare for that particular set of tragedies, there's something that we missed. We missed all of the other kinds of tragedies that were predictable and that were preparing to unfold for all of us. And I think that is, as we took a breath between the first wave and prepared to head into this second wave that most health systems are now experiencing, we perhaps didn't take quite enough time to think about those other kinds of tragedies that we're going to be talking about tonight. And those are, of course, these kinds of tragedies that impact on people's health and well-being, of the economic impact of shutdowns, the racial and income and class divides in terms of who has been affected most fully by the pandemic, the waves that we now see happening in Indigenous communities, beginning to happen in Indigenous communities across the country, the impact of deferred and canceled care of all kinds, and the critical impact on our seniors, on the elders of this country, many of whom living in long-term care facilities didn't get a chance to even say goodbye face-to-face to their loved ones. And all of these are also tragedies. They're not the kind of tragedies that make for high drama television shows around deciding who's going to get the ventilator and who won't. And yet, nevertheless, they've been very real tragedies for thousands and thousands of Canadian families, and will be critically important as we can consider what kind of world we want to build coming out of this pandemic, something which I know Thomas Homer Dixon is going to be talking about later on in this conference. And so I think one of the things that we have an obligation to do as we look at headlines like the ones that you see on this slide is to ask ourselves, how much of this was really news? Is it really news to any of us that we have an opioid epidemic in this country? Is it really news that long-term care has been under-resourced and that our seniors have been put in situations that are in some cases truly untenable with respect to the quality of their care through no fault of their own or the workers in those facilities? Is it truly a surprise to us that people who are experiencing homelessness are at much higher risk of terrible health outcomes than those of us who have a stable house, a stable home in which to live? And the answer is, of course, none of this is news. None of this should have been news to us. All of this pre-existed COVID-19. And so while it's important and indeed critical to document the ways in which those cracks in our health and social systems have become chasms for so many Canadians, at the same time, it's really important not to kid ourselves that these are things we didn't already know something about. And so when you look to the literature to ask, well, what do we know about the pre-existing issues? Because I'm a healthcare person, I'm mostly going to focus on healthcare this evening. What did we know were the pre-existing issues before this pandemic hit our shores in Canadian health systems? And the answer is, broadly speaking, there were three areas where Canadian health systems were at risk of lagging behind with sometimes catastrophic consequences for people. And those are these. The first, and I'm going to spend some time talking about each of them. The first, of course, is wait times for elective care, something which I know you talk about a lot in Alberta. We talk a lot about in Ontario, and indeed across the country and outside our borders. Canada is famous for all kinds of wonderful things about our health systems, but one thing that we're famous for that we're not so proud to be famous for is the fact that people wait sometimes too long, in my opinion, for planned or elective services. This, of course, does not mean that people are exsanguinating on the sidewalk, waiting for care while being told to take a number. It does, however, mean that we have serious issues with respect to accessing planned surgeries, non-urgent and non-emergent specialty appointments. And sometimes those waits have an impact on the quality of people's lives. And therefore, we shouldn't be afraid, those of us who believe in advancing health system improvement and equity in this country, we shouldn't be afraid to talk about the fact that those wait times were long, even pre-COVID, in some cases too long, and that there are concrete, evidence-informed ways of dealing with wait times that don't sacrifice our values. In my opinion, we've never been well served by the rhetoric that says there's no problem with wait times. Anyone who works in Canadian healthcare, anyone who's been patient in the Canadian health system knows that we face those challenges, not when we're seriously sick, not when our lives are on the line, but nevertheless, that grandparent who has to miss a golf season because they're waiting for a hip replacement and can't walk the green, that teacher who has to cancel too many days of work because of migraines, waiting for an outpatient neurology appointment, that person who has difficulty, has to give up their hobby because they can't see well enough to continue it while they're waiting for their cataract surgery. These are important things in the quality of people's lives, and we can do better and must do better. And we're going to talk a little bit about what that looks like. The second critical challenge facing Canada's health systems pre-COVID is the reality that outside of the core basket of physician and hospital services, people face very unequal and inequitable access to critically important healthcare services. Just to name a few, access to prescription drugs, access to home care, access to mental health services not provided by a physician, access to home and long-term care and dental care, and the list goes on. And when we talk about the expansion of Medicare and why it is that when a patient comes to my office as a family physician, I can, spend 45 minutes with them if I need to. I can do a complete physical examination. I can deal with their issue. I can send them for a test. I can refer them to a specialist. I can send them for advanced diagnostic imaging. I can give them a diagnosis. But the minute that I put pen to the prescription pad to give them a treatment for what ails them, that person is completely on their own. An absurd and shameful, in my opinion, legacy of the way that we constructed our health systems in the 1960s and have failed and failed again to modernize them. A problem that is only, as we're going to discuss, worsening as a result of the pandemic. And then finally, the final challenge that predates COVID that we're going to talk about this evening is the critically important nature of the social determinants of health. The fact that nothing that I do as a doctor or as a hospital leader, and nothing that any healthcare worker on this Zoom conference tonight does, is as important to the health of the communities we serve as ensuring that our kids have a decent public education, that people have access to safe housing, to a nutritious diet, and to live free of racism and discrimination. These are the things that matter most to our health. And we headed into this pandemic with these cracks pre-existing in our health and social systems. And so we shouldn't be surprised then at the outcome. We've talked a little bit about wait times, and we're going to talk a little bit more about them now. I suspect we'll talk about them again later on in the question and answer and exchange period, because of course we know that non-urgent care, wait times for non-urgent care are and continue to be, have always been, or at least for a few decades now, been one of the major areas of bones of contention in the Canadian healthcare system. And of course, those of you who are in Alberta are having this debate yet again with the tired old rhetoric that we're hearing about that the answer, of course, is then to privatize services and allow people to pay for their care, an argument that's now been struck down by the Superior Court of British Columbia in the Canby trial, and that we know is not an evidence-informed perspective. We know that allowing some people to pay for their healthcare only lengthens waits for everybody else. But nevertheless, we do have an issue around wait times. And in case we thought that the pandemic was going to liberate us from that, instead what we found is that we find ourselves in a much more difficult situation. The statistics are pretty striking. Thousands and thousands, and indeed tens of thousands of surgeries, diagnostic imaging investigations, procedures, and non-urgent specialist appointments were canceled during the lockdowns of the first wave. Nobody's gonna, it's pointless to do so, and B, it's an academic exercise to debate whether we went too far in the lockdowns in our health systems or not. But I hearken back to what the tragedies and terrors were that we were preparing for in our health systems. We put every ounce of energy we had, all of us, into trying to liberate every bed we could, every nurse we could, every doctor we could, every mask we could, every procedure room we could, in case of the worst case scenario. And I think that that was a perfectly legitimate choice to make, but it had consequences. And the consequences were that we took a system that was already stressed with respect to non-urgent and non-emergent care, and now we have stressed it further. And we're going to need to think really carefully about how we're going to deal with that consequence as we come out into whatever the post-COVID world is going to look like. If we don't think about it and don't get ahead of it, if we don't bring progressive solutions to the table for the appropriate and equitable allocation of our resources, we may end up with solutions that most of us would prefer not to live with. The second issue that I want to talk about is access to prescription medications. Some of us, and I'm sure many of you participating in this evening's conference are among them, have been very engaged in the work around trying to advocate for the institution of national pharmacare to bring prescription medications, among other services, underneath the Medicare umbrella. And boy, did it feel like we were getting close just before the pandemic hit. Of course, now we're hearing next to nothing about Pharmacare. And the irony of that shouldn't be lost on any of us because, of course, all over this country, as a result of the economic impact of the lockdowns and of the pandemic itself, people are losing their jobs. And when you lose your job in this country, if you have a decent job to begin with, and you're not in the gig economy or a part-time shift worker or on contract, when you lose your job, you lose your drug coverage. And so we have put people in the same situation that we wag our fingers at our American cousins for, having their health benefits depend on their employment. And as Nadine Caron and I have written in this paper I was referencing earlier, we find ourselves in the extraordinary circumstance that if we were to see the advent of a miracle drug that cures COVID, a pill that you could pop at the first sign of your diagnosis to prevent you from getting sick and ending up in the emergency department or the hospital or heaven forbid, the ICU. If we were to end up with such a pill, of course, millions of Canadians would not be able to access it. And so we really are in a situation where access to pharmaceuticals is becoming critical. And as we see the ripple economic effects of this pandemic for years and decades to come, we should not forget that in addition to losing your job, you lose your access to your life-saving medications in many instances and to your mental health care. As we're seeing the impact of this pandemic on people's mental health across the country, people are suddenly finding themselves without access to psychotherapy, without access to social work, without access to cognitive behavioral therapy. And I'm going to talk a little bit about where I see some of the unlocking of these log jams happening in the later part of my talk. But I think it's critically important that we acknowledge the very difficult situation that so many people are finding themselves in, with being doubly hit through job loss and loss of benefits. Canadians now are twice as likely to have lost their prescription drug coverage as to have gained it, and some pretty shocking projected statistics with respect to mental health impacts and suicide, which is not uncommon during massive catastrophic events of the kind that this pandemic, the category that this pandemic finds itself in, but pretty sobering when you consider that we're allowing people to lose access to coverage for medically necessary prescription medicines and therapy at the same time. Finally, we can't have a conversation of any seriousness at all about health and health outcomes without talking about the social determinants of health. And as everyone knows, the most important impact people's health is not the impact of the healthcare system, but indeed those famous social determinants of health that include things such as income, access to supports for appropriate early childhood development, systemic racism, housing, and the list goes on. And so really, if we're serious about discussing health, we need to be talking not just about healthcare, not just about ventilators, not even just about vaccines, but actually we need to be talking about how we're going to prepare people and increase their chances of having a healthy life. And that is something that we cannot duck when it comes to COVID because of this. Because we know that in addition to 80% of the COVID-19 deaths in the first wave occurring in long-term care facilities, that this pandemic is not a pandemic in which we have all been in this together, that persons' racial status and their experiences of systemic racism influence all kinds of things, including their likelihood of contracting COVID-19. These data are Toronto Public Health data, and they show you the proportion of the population in the green bars in the city of Toronto, where I live, the proportion of the population who self-report as being white, Southeast Asian, South Asian or Indo-Caribbean, Latin American, East Asian, Black, Arab, Middle Eastern, or West Asian. And as you can see, if you are white, like I am, you make up 48% of the population of the city of Toronto, but only 17% of the COVID cases are among people who self-identify as white. And if you are Black, you make up 9% of the population, but 21% of the COVID cases. I find this slide truly staggering. It tells a story about who is taking the bus to those essential worker jobs, who is putting their life on the line as a result of the environments in which they live and work, who's more likely to get the care that they need. And if we're not attentive, if we're not collecting the data, if we're not reporting the data, and if we're not doing something about the data, then we can keep putting people on ventilators, but we're not going to get to the bottom of a phenomenon like this. Having thoroughly depressed you all now, the critical thing that we need to talk about is what can we do about all of this? And as I began by saying this evening, none of what I've just articulated should be news to any of you. These should all be things that we all already know and acknowledge. The realities around wait times, around social determinants of health, and around access to services outside the core Medicare basket are not new. But what is new, it turns out, after generations of talking about these issues, of reading about them in the newspaper and in the peer-reviewed literature, that when we're backed into a corner with almost no other option, it turns out we actually are capable of doing something about it. That is what I would like to talk about. As these cracks have become chasms, we have learned that there are ways that we can open up these traditional log jams in Canadian healthcare and begin to think about how to do things in a different kind of a way. And one small example of that has been the rapid pickup of virtual care across the healthcare systems of Canada. This isn't just a Canadian phenomenon, of course, overnight across the developed world, both for a number of reasons, of course, for the conservation of personal protective equipment, to enhance the capacity to do physical distancing and therefore reduce the risk that people contract the virus in a healthcare environment. And also in order to allow people to adhere to public health advice to stay home and stay safe overnight. We have managed to modernize our healthcare systems such that people are able to access advice from a physician, a nurse, a dietitian, a social worker, a psychotherapist, either by telephone or by video, whether it's Zoom, FaceTime, or you name it, overnight. In organizations like my own, I work in an ambulatory hospital with no inpatient beds. We went from less than 10% of our patient interactions occurring through some kind of virtual means overnight to 85%. And that's probably not where we want to stay forever. Some forms of healthcare interactions do require the laying on of hands. Some of them do require a face-to-face visit. Some of them require, of course, procedures, but not all. And I will tell you, as a family doc who's been providing virtual care since the outset of this pandemic, it turns out that there's quite a lot that can be very effectively done through a video visit or a telephone visit. And it's a very interesting shift in the balance of power when people don't have to take half a day off of work to come and sit in my waiting room and wait for me, but instead I'm calling them on their time to have that healthcare interaction. And the pendulum finds the right place to swing to in the post-COVID world. I think it's really important for us not to allow inertia to pull us back fully to where we were. We need to think about all of the ways in which people's facility with the use of virtual tools in all industries and including in healthcare can be used for the better. And just to share a little story about that, because I know that there's a lot of concern around the digital divide and who's got access to video to conduct a virtual visit, etc. I was speaking with a colleague who works with some of the most underserved and marginalized populations in Toronto, including sex workers. And she was telling me that she instituted very early on in the pandemic a telephone line that women could call when they had a health concern. And they were basically told, you know, if you just call this number, you'll be able to speak to a doctor. And she said to me that she had unbelievably moving interactions on the phone with women who she knew would never have come in for a face-to-face visit for a whole variety of reasons. Either they were not living in circumstances where they could easily get out to make it and come to a visit, or come on time, or come during, you know, her office hours, or they were in situations where in some cases they felt shame about presenting for the issue at hand. And she said to me, you know, one woman expressed to me that she was so glad to be able to speak on the phone because she was embarrassed. She didn't want me to see her teeth. And that really stuck with me, because I think that there are lots of ways in which we can design virtual care services actually to close gaps and to reach out to people who have never been well served by the way that our health systems have been structured, if we're paying attention to what those people are telling us. And so virtual care does not have to mean, high volumes of unnecessary visits for the worried well on FaceTime. Virtual care can actually be used as a lever for enhancing health equity. And in my opinion, it's a critical lever for that enhancement. Secondly, with respect to wait times, it's extraordinary to me that it took a complete lockdown and shutdown of elective surgeries to finally get us to the place in Canadian healthcare where surgeons were willing to talk to other surgeons and hospitals were willing to talk to other hospitals about taking a rational approach to wait times management. We finally are in a situation where the notion that people should be prioritized across a region and not just on a single doctor's list has finally become not just a good idea academically, but an expectation. And as we find ourselves now on the cusp in the province where I work, on the cusp of what look like some pretty dark times with respect to case counts, we're now seeing hospitals in a region coming together and saying, well, we better take all of these surgical wait lists and merge them together, figure out who's the highest clinical priority across the whole of the city or the region, and allocate our time accordingly, because we're not going to be able to run at the level and the volumes that we were before. And of course, that was always the way to get rid of wait times in Canadian healthcare. And yet it's taken a pandemic to get us to the point where we're prepared to have that conversation. My colleague, Dr. David Urbach, who's the chief of surgery at Women's College, and I worked on this paper together in between the first and the second waves, in which we talked about the possibilities of using this moment of crisis to look at the way that we manage our surgical care in Canada. And, one of the critical elements of this is what's known as single entry models, something which I talk about in my book with respect to two places where you may remember visiting. One is the grocery store and the other is the bank. What happens when you go to the bank? Do you stand in line, each person, each teller with his or her own line, or do you get into a single line and then you're served by the next available teller? Being served by the next available teller is an example of a single entry model. This is in contrast to what happens when you go to the grocery store. You go and pick up a few things, you put them in your cart, and then you get to the checkout and you start doing that dance, trying to figure out which line is moving more quickly, and hoping that the person in front of you, doesn't have to count out exact change from their wallet. And you can see that the line next to you is moving more quickly. Well, that's how we've always managed our wait times in Canadian healthcare. Each surgeon, each healthcare provider, each specialist, each MRI machine with its own wait list. And even if that wait list is prioritized according to clinical need for that individual provider or service, we're not prioritizing across lines, and we're not putting people into a single common queue to be served by the next qualified available provider in their region. And if that is one of the silver linings of this pandemic in Canadian healthcare, is that we're finally able to unlock a serious conversation about how to use the resources that we have more effectively to minimize people's waits, then I think we will have learned something very, very valuable, albeit, of course, at a very high price. And then finally, I just want to say a few words about the universal basic income, because there's a lot of conversation happening across the country about what the universe will look like in Canada around income supports as we head out of this very dark period. And I want to give credit where credit is due. I think the government of Canada acted rapidly to put in place income stabilizing measures like the CERB that for many people made the difference between being able to pay their rent or not, being able to pay for groceries or not. And that, I think, has finally unlocked the conversation about what does a modern economy look like that provides income supports to people, rather than forcing individuals to fill out reams and reams of paperwork in order to prove their worthiness for some tiny amount of social assistance, to simply put in place a system that functions in some way, shape, or form through our tax system and allows every individual whose income falls below a certain level to get topped up. That is the future, I think. That is what the modern state support needs to look like for people who, especially in a gig economy where people are in and out of jobs. And so that is a critically important lesson coming out of this pandemic, that actually government can act. It can act rapidly, and it can act to stabilize the incomes of people who are living on the edge. And if we don't take advantage of that lesson, in order to shape a better world as we come out of this pandemic, then I fear that we will have missed a truly golden opportunity. And so in closing, I'd like to say that I think we would all prefer to have learned these lessons through some other way. There are a lot of people who have suffered and unfortunately are continuing to suffer as a result of the pandemic. But as we think about what are the gifts, if I can put it that way, of a very dark time in this country's history, there are a few, and there are a few specifically in the healthcare sphere that we want to hold on to. The first is that we actually are capable of making change. When I say that we're capable of making change, I mean in the way that we organize and deliver our services, whether it's through virtual means, whether it's through collaboration across jurisdictions, whether it's the way in which we take suddenly very scarce resources and allocate them according to some transparent and clear set of parameters. And the most important thing, of course, that we can do for the health of people is to structure systems that will catch each of us and all of us in our moments of vulnerability. And that means expanding our public systems to include modern definitions of what health and healthcare are about, and expanding our social services, including our income support services, to reflect the realities of the 21st century. It's up to us to decide what we're going to take out of this pandemic. And although some of those lessons have been learned truly the hard way, I think there are many pearls. Thanks.
Danielle, that was amazing. Thank you so much for taking the time with us this evening. Danielle, I've got a couple of questions here, and I'm going to start with the Executive Director of the Friends of Medicare, Ms. Sandra Azakar, and she asks, recognizing the importance of virtual care, can you speak to third-party platforms such as Babylon Health that do not necessarily add to the expansion or modernization of our healthcare, but rather to allow private and for-profit third-party virtual health providers?
Sure. Thanks for the question. Of course, virtual care means different things to different people. To me, virtual care cannot and should not be something that stands alone outside of the healthcare system. I'm not talking about virtual walk-in clinics when I talk about virtual healthcare, a method by which instead of calling or walking in to see a provider who knows nothing about you, has no relationship with you, has no access to your chart, has no way of communicating with your other healthcare providers, and will never see you again. To me, that's never been good healthcare. It wasn't good healthcare when it was delivered face-to-face, or when it still is delivered face-to-face, and it's not good healthcare when it's delivered by a bot, and it's not good healthcare when it's delivered by a person through a screen. But as a family physician with 15-year relationship with my patients, is it reasonable for me to have everybody come in to see me just so that they can update me on their blood glucose readings for their diabetes and have a conversation about when are they due for an eye check? I would say not. I would say actually that was at my convenience and not at the convenience of the individual. We have to get real, those of us who work in the healthcare system, about what it truly means to shift the balance of power between healthcare providers and patients. And that means upending our assumptions about what it means to have a truly so-called patient-centered or client-centered or people-centered healthcare system. So I'm personally not a big fan of third-party platforms, whoever pays for them, whether they're publicly paid for or whether, certainly not if they're paid for by the patient out of pocket, not because I have some sort of religious opposition to them, but simply because I don't think that that's actually good healthcare. Good healthcare looks at the person, looks at the issue that they're dealing with, and in the context of a continuous relationship of some kind, there's an exchange in which it's determined what is the best way to deal with this person's issue in this moment. And sometimes that's a phone call, and sometimes it's an email, and sometimes it's a secure message, and sometimes it's an e-consultation between me as the family physician and the specialist, with the patient actually never coming in direct contact with the specialist at all. Sometimes it's me calling to get advice from a therapist about how to best handle this person's knee pain. They don't ever have to go to physio themselves. And sometimes it's a face-to-face visit. And so thinking more about the way that we can use these different channels to sub in for, we used to just give people a face-to-face visit because that was literally the only product we had to offer them in healthcare. And that to me is not good enough. And what this shift to virtual care, I hope has done, is that it will demand of us as healthcare workers that we consider what the full range of channel is and then what the best is for the particular individual in question. But that needs to be integrated with their in-person care, their face-to-face care, not standing alone and outside of it.
Danielle, you nailed it. I think that's fantastic. One of the things that we watched, it was almost somewhere other, a foreign land in Ontario, when the military came into the long-term care centers, and the horror that we watched from there. And I fear that we are on a steady path towards similar here in Alberta. And the question that I have for you from Annie says, what are your recommendations for the restructuring of long-term care to best protect our seniors?
It was horrifying, I have to say, as we all should, a profound sense of shame to live in a place where this is how we treat our elders. So I'll begin by saying this is not my area of expertise, but I have thought about it and spoken with colleagues who know more about it than I do. And there are a few things that leap out. The first is obviously that in the context of Ontario, for-profit nursing homes and for-profit long-term care facilities performed much more poorly than the not-for-profits. A lot of that probably relates to the differences in skill sets and ratios of providers to patients or to residents, number of hours of care that people were able to provide. We need to look very seriously about the role for-profit chains in the delivery of any kind of healthcare service, but certainly in the context of long-term care. Fortunately, and I take no joy in saying this, that some of these chains really have got a lot to answer for with respect to how people were treated in these facilities where our loved ones were being taken care of. What are my recommendations? Well, this is what I know. I know that some minimum standards around the number of hours of care provided to each resident in a long-term care facility seems to be table stakes in any serious conversation about long-term care. I know that the balance of the mix of providers in that environment also matters, and that is not in any way to devalue the RPN versus the RN or the healthcare aide versus the RPN, but simply to say that you need a mix of folks working in an environment, and everybody needs to feel backed up and supported by the other members of their team when they start to feel that they're getting in over their head with the care of a resident or a patient. Certainly, one of the things that is critical is that we can't have, especially in a pandemic, but probably really at any time, workers moving back and forth, having to hold down multiple part-time jobs in order to make rent. We know that in BC, and there's evidence that's now been published in the literature about this, that in BC, where I'm forgetting the name of the rule, but the rule that basically said you could only work in one facility, BC instituted that rule more quickly than Ontario did and probably saved hundreds, if not thousands of lives in doing so. But the reason that people are working multiple jobs is not because they really enjoy all of that time spent on the bus. It's because they need to make ends meet. And so that is closely linked to what we pay and the benefits and other contractual obligations that we have to the workers in those facilities. And none of those are my recommendations. Those are the recommendations that I'm reading, that you're all reading in the literature, and they're all part of the solution. And I do think that we have a serious reckoning to be done in this country around the care that we give. Of course, it's not solely seniors who live in long-term care, but it's mostly seniors. And of course, as we age, we also know that that means it's mostly women. So we really need to think about what we're saying about the matriarchs of our communities when we put them in these places where it is not possible to keep them safe.
Thank you, Danielle. I think we call it the single site order.
Thank you. Thanks, Mike.
In
Yeah,
Alberta.
that's
I don't
right.
know what BC calls it. You're right. It is our most vulnerable in these centers. My next question is a three-parter. So I'm going to give you all three pieces and we can work our way through it together. Okay.
Sure.
Please explain what is the privately, in quotes, funded and privately managed healthcare system that the current government in Alberta, the UCP, has recently approved as a policy at their AGM? And will it help in addressing the three major issues you described in the claim? That was part one. You said that no one is talking about Pharmacare anymore. I'd love to speak on that one, by the way, but I'm going to let you take care of that. And number three, what do you say to an anti-masker? It almost feels kind of warm, doesn't it?
Yeah. On the first part about what does the UCP mean by privately funded and privately delivered healthcare in Alberta, I truly have no idea. What I can say with absolute confidence is that if the UCP in the resolution that they passed at their annual general meeting are talking about allowing or encouraging Albertans to pay out of pocket for services that are covered by Medicare, then that's illegal. It is a contravention of the Canada Health Act. And more importantly than that, it undermines the values that Canadians almost universally hold very dear, the value that access to healthcare should be based on need, not ability to pay. I see the resistance to these proposals. I'm reading about it in the papers. Of course, I'm not in Alberta and I don't have a handle on all of the granular details about what's going on. I cannot imagine what is being talked about in that resolution, nor do I frankly think that it's worth much consideration. Do I think that it would solve the three issues that I have talked about tonight? The evidence on that is a resounding no. The evidence is that when you introduce parallel private pay, and this has been shown over and over again in studies all over the world, when you introduce a parallel private tier, you make the wait times longer in the public system. And that is because we do not have an ocean liner full of extra doctors, nurses, technologists, and other healthcare workers sitting off the coast of Newfoundland ready to come and staff this parallel private system. The people who will staff that parallel private system are you and me. And when we leave, because the money is better on the private side of the house, that's going to leave longer wait times in the public system. And so it's not a solution for any of the problems that ail us. And indeed, it would exacerbate the problems that we face.
What do you say to the anti-masker as you're walking down the street?
I have a really hard time with this one, Mike.
Yeah, no, I
have
hear
a
ya.
really hard time with that. I mean, what do any of us say? I'll tell you what I say to the person who hesitates around vaccines in my office. You know, when it comes to vaccines, the conversation, I suppose, is not dissimilar. I think most people are not actually anti-vaccine. Some people are hesitant. There's a lot of information out there online that may be confusing to people. Most people are more than happy to vaccinate themselves and their kids. I don't believe in shaming and screaming at people. I don't actually think that it's a very, productive way of running a society. I don't think that we have a ton of anti-maskers in Canada. I think what we have is a lot of people who are tired. And I get it. I am tired too. And we see it even all over, hospitals and other healthcare environments. People are exhausted. They just want to take their mask off and eat lunch. They just want to have dinner with their grandma. They just want to make a plan for Christmas that feels normal to them or whatever. Like, I understand that. I really do. And I think that all we can do right now is to try to be patient with one another and kind to one another as we round the corner. And I do think that the news this week about possible, two possibly very efficacious vaccines coming down the pipeline, I hope will give us all that little jolt of hope that we need to kind of buckle down and just keep doing what we can until we have other means of protecting ourselves other than the masks.
I think that's right on. And I was just writing down the words "be kind" as you were saying. I mean, you're absolutely right. Like, it's really tough right now, and our frontline medical staff are now becoming our last line of defense.
Right.
They are exhausted and nobody is giving them reinforcements. They need a bit of a backup. The second question that was on Pharmacare. Why aren't we talking about it anymore?
It is shocking, isn't it? Because think that this would be the time. And in fact, there's a new survey out just for Angus Reid Institute. Angus Reid Institute just put out yet another poll in the last week or two around Pharmacare, showing that huge numbers of Canadian families are not filling their prescriptions because of concerns about costs right now, and that huge numbers of people are losing their drug insurance. Here we are in the middle of a pandemic. You would think that health and healthcare could never be more top of mind. People losing their jobs, losing their drug coverage, and ending up in the emergency department with preventable complications of their diabetes, their hypertension, their heart disease. Person I know socially just had a heart attack, ended up in the emergency department in the hospital. He's a gig economy worker and definitely doesn't have any drug insurance. This is real, like, it's happening to real people. I will say that the CLC has been extraordinary in its advocacy for Pharmacare. And as have many, many other groups across the country in the labor movement and outside the labor movement. And why aren't we talking about it? There is no good reason why not. And the notion that somehow we can't afford it now at a time when we are paying for the downstream consequences of not having pharmacare is absurd to me. There's no good reason we should not let up. This is not the moment to let up on the pressure.
100%. One of the things that you really rung in my ear on was to say, if there was a pill and you had to pay for it, and I put a dollar to my head, I said, if it was $100, Canada-wide, North America-wide, the pill's $100. If you can afford it, you can get it. How many people could?
Right.
For the COVID vaccine. I'm going to combine two questions together here from Nancy and from David. The first one says, how do we filter these solutions and ideas to provincial health systems and governments? And the second one is similar. Give me your top 3 strategies to flatten the curve in healthcare costs. So I think these are strategies and solutions kind of all working in together. Danielle?
You know, it's interesting because for a long time, this book that came out, I had been doing a lot of public speaking in the last 5 years, trying to get Canadians to filter those solutions, because I had come to the view that actually this conversation about how to improve healthcare had resided too long in the corridors of health system administration, and the system was paralyzed. Nothing was changing and nothing was happening. And the only solution I could see through to was to get people engaged to demand those solutions of our political decision makers, of your local MPP, of your local hospital CEO, of your local health region, regional health authority leader. So I was putting a lot of energy into trying to encourage people to pick up the phone and say, hey, hospital CEO, I'm calling to ask you why it is that each of your orthopedic surgeons has their own wait list, when everybody knows that the best way to reduce the wait times for hips and knees is for them to share that list. And yet, I think that something has shifted in the pandemic, that we have actually unlocked a little progress in a number of these areas. This comes to the top 3. For me, pre-COVID, I would have said that the top 3 interventions that we could put into place, and these are not my ideas, these are well-documented concepts in the health policy literature, were number 1, single entry models. So this notion of the single common queue, the teller, the bank teller versus the grocery store. Number 2, the appropriate use of virtual care. And by virtual care, I don't just mean fancy video visits on your iPhone. I also mean e-consultation, which is a very important way to reduce wait times for specialty care. For those who aren't familiar with it, it's a method where you go to see your family physician or your primary care provider with an issue. They're not totally sure what needs to happen. Instead of putting you on a 6-month wait list to see a specialist, they just send an email to the specialist, and the specialist responds within 48 hours. And then they call you back and you implement the specialist's plan. And so it's about getting rapid provider to provider advice rather than sending everybody off to the specialist. And then the third is appropriateness. So trying to reduce the number of people who are waiting for stuff that actually isn't going to help them. You would be shocked to discover how many people are waiting for an MRI of their low back, where it's going to make absolutely no difference to their management. They just need to go to physio. Really taking a hard look. And all 3 of those things have been unlocked in this pandemic. So we don't need to filter those solutions to decision makers anymore. What we now need to do is prevent retrenchment. It's going to be really hard to prevent that backwards slide, especially when the money feels tight, because we know that the austerity is coming at the end of all of this. It's going to be hard to prevent that backwards slide, and we are going to have to maintain those gains and protect them for the improvement of the health system.
Danielle, in all of these comments that you've just made, private for-profit system doesn't fit into anything that you have just said. I want to put that on the table right now. My next question comes from Luann Metz, and she is the spokesperson for Eyes Forward. And this is an organization out of Calgary. It's a grassroots group from Calgary. And her question is this: in Calgary, most medical specialties moved to central access and triage over the last 5 years, dramatically reducing most wait lists. Is there any identified reason why surgeons, not all, have been so resistant to this change?
So first of all, Leanne, congratulations on your advocacy. Nobody really loves the speaker that refers to their own work too much, but the paper that I made reference to, that David Urbach and I put out in CMAJ earlier in the pandemic, does talk about this. And I want to honor, I work with as I'm sure you all do, extraordinary surgeons. So, this is not about me giving a hard time to the surgeons. I think the reality is that change is hard. Change is hard and nobody wants to do it. And people come up, they grow into their practices in a certain kind of a way. And it's hard to imagine doing things otherwise. I will confess that I underestimated the extent to which it is a emotional transition for a surgeon to imagine that they are not building a personal one-to-one relationship with their patient in the way that the kind of old system implied. And the notion of the referral from me as a family physician to you as a surgeon as a kind of a personal introduction, and the relationship that you have with me as the referring physician, and what does it mean to just take a referral that I sent you and hand it off to somebody else? Like those, I had underestimated the emotional impact of asking people to make those changes. And I have learned that the resistance to it is real, and it's not just a resistance about money or power or hanging on to your own wait list or whatever. It requires a reimagining of what it means to be a medical specialist or a surgical specialist. But why is it that the specialists in Calgary have been able to do it on the medical side and not the surgical side? I mean, I would turn that around and ask you, what was the magic that was applied in the first instance? And can you get a little bit of that magic and sprinkle it onto your surgical colleagues so that we can move this along? Because I do think that on balance, I mean, of course, there are some cases and some instances where there may be only one person in the region who should be doing this case. There may be a really good reason why a patient wants to wait for Dr. So-and-so, even if that means that they're waiting longer. And I'm not talking about taking away everybody's, ability to have a say. But I do think that that we need to be building systems where the default is the next available appointment with the qualified person who can take care of your issue. And actually, most of my patients are perfectly happy to know that they're going to be seen faster by somebody competent and qualified when I put it to them that way. And so the last thing I will say is that some of that onus is on people like me at the primary care level to explain to our patients, no, I'm not sending you to a nameless, faceless system. I'm sending you to a group of highly qualified, amazing providers, any one of whom I would be happy to have operate on me, and you will be in good hands, whichever one of them it is who replaces your hip. And if I put it to my patient that way, it's going to go just fine.
That's perfect. One more shameless plug for Eyes Forward for anybody on the line tonight. Go have a look on Facebook and track them down. My next question comes from Trevor Harris, and he says, how much of our healthcare problem are as a result of a just-in-time production model, which has prevented the useful degree of redundancies to be called upon during our time of crisis like right now?
It's a very interesting philosophical question. I think you can run that question both ways. I'm a evil hospital administrator. One of my jobs is to try to make sure that every hour of operating room time gets used to operate on a patient. I can't stand the thought of nurses and surgeons standing around when there's all these people who need taking care of with nothing to do and nobody to take care of. I will also say, frankly, that the reality of the Canadian healthcare system or the health systems across our country is that if I were to run a hospital where only 75% of our operating time got used, I would run out of surgeons in a hurry, because those people, men and women, are all paid on fee for service. We have to acknowledge that, they make their income by taking care of patients. Having said that, is it wise to run so close to the razor's edge that you're already at 98% capacity before flu season comes? Of course not. Of course, that's not wise. It's not safe. It's not safe for workers. It's not safe for patients. Where exactly would you saw it off? I don't know. I will say that the lesson from the US, and indeed from all over the world, is that there is no such thing as redundancy, in the sense that when you put providers into a place, they will find somebody to give healthcare to. And so the unintended consequence of creating, of training extra, if we can put it that way, extra people, or creating extra capacity in the system, is that somehow it always seems to get filled up. but the stuff it gets filled up with is increasingly of lower value, if you will, lower value to the health of the patients. I mean, I'm not sure that the kind of health economics literature would support the notion of building redundancy. Have we been cutting it too close to the wire in terms of the number of hospital beds across Canada? I think that the evidence would say, yes, we've been too close to the wire.
I think you're exactly right. We've got less beds today than we had 20 years ago in Alberta. You can watch any newspaper to see the code reds of our EMS system. Everything it was too tight, as you said. And now it's just at a breaking point. From Rebecca, she says, how can advocates for expanding universal health care to include pharmacare, mental health, long-term care, and dental push back on that narrative of affordability and sustainability and who's going to pay for it? Can we afford not to?
I think the biggest way to push back on it is to point out that we're paying for all this stuff anyway. So I'm just going to speak a little bit about Pharmacare for a moment. It's not as though the alternative is that nobody gets any prescriptions. The alternative is that the prescriptions get paid for at higher prices through private plans and out-of-pocket spending, and huge numbers of people can't afford their medicine at all, and we end up spending more. So every economic analysis of Pharmacare clearly shows that we would save money and cover everyone if we were to put universal pharmacare in place in Canada. Why? Because we would actually be able to negotiate centrally on the pricing of our drugs with the pharmaceutical companies the way that every other country that has universal pharmacare does. And we would be able to move to systems of prescribing that are of higher quality and lower cost. There's absolutely no doubt that we could cover everyone and probably spend less than we currently do overall. But yes, of course, that's about total spending. There would be a necessary shift of expenditure from the private sector to the public sector in order to make that happen. So now we're just talking about how you're going to finance it. What is it? The corporate tax structure? Is it a payroll tax? Is it, and all of these things have been fully worked out. I mean, there are economic papers on this until you're tired. There is no absence of evidence about how to structure this thing so that it works and isn't too expensive for Canadians. We are not missing the route forward on the economic side. The only thing we're missing is the political will. And I don't know how to create that other than through all of us, doing something about it.
Danielle, you said it earlier that governments can act if they want to, if they're motivated to, and if they fear they're going to lose their bloody seats. And maybe that's where some of this has to happen, right? My next question for you is, I'm going to say that there could be a conversation on how taxes are paid, but here's how it's framed. What do you think the role of the ultra wealthy is in the new reality? How do you think we can get them to acknowledge that it is their responsibility to the society that got them to be so wealthy? I would suggest they should be paying some taxes that they just voted down recently in the House of Commons, but I'll listen to your perspective.
This is outside my realm of expertise. I will say that, as a Canadian physician, I'm a high income earner. And I am incredibly grateful to live in a community where my kid can go to an excellent public school and I can go to work every day and be well paid through the public purse. And I am happy to pay my taxes. I'm thrilled to do so. I don't think I would qualify as a Canadian doctor as an ultra wealthy, but I will say that among many other people in this country would be very happy to pay higher taxes if I knew that it was going to make a difference to the world that my kids are going to inherit. And I can only answer that as an individual because I'm not an economist.
Thanks, Danielle. It's a tricky one, but I appreciate your comments. I'm going to go to a frontline healthcare worker named Heidi that's got a question on here. These pandemic positives, like addressing surgical wait times across a region instead of a single provider, enabling online access to practitioners, even the general benefit of increased work from home flexibility. How optimistic are you that these improvements will stay in place long after this pandemic passes? Maybe it's the fatigue from being our oppressed conservative government, but I can't help, and it just moved. She's a frontline healthcare provider out there in Alberta today, seeing the weight of all of this. You think some of these things that are here today are still going to be here when that pendulum does come back down?
all I can say is I think that's up to all of us, isn't it? You were saying, Mike, earlier that, well, maybe sometimes governments will move when they're afraid if they'll lose their seats. But of course, it's not just governments, it's us. I mean, what is government? This is a democracy. We're voting for these folks. We're giving them the power to make these decisions. We can take that power away. To me, what's going to be interesting and difficult and worthy of big social conversations like the ones we're having tonight is what is the right place for that pendulum to swing back to? Like, I don't think that most people want to work from home all day, every day for the rest of their careers. Many people actually used to like going to work and sometimes seeing their colleagues and having a meeting face to face. I certainly know that many women would be very happy to get out of the house when their kids are doing homeschooling, et cetera. So, I mean, I say that facetiously, but not completely facetiously. So how can we come back to a place when all is said and done, when it's not critical to the health of the public that everybody stay home all the time? How can we come back to a place where it is looked at as a appropriate level of workplace flexibility? And how can we move to a place where, okay, maybe it's not going to be 85% of the care will be virtual, but maybe half of it will be. And how will we determine which half? And who gets to make those calls? And how do we make them together? How do we make sure that some people don't get left out of getting care when that pendulum starts to swing back? And I actually think how delicious concept that we might be able to sit around and have those conversations about what the afterworld is going to look like. And we're going to have suddenly the full range of options available to us. And then we can really debate, hot debates about what exactly is the right balance to find, and we'll get it slightly wrong and we'll, sort it out over time. I actually look forward to that because the stakes will not be quite so high as they are right now.
I think you're exactly right. When you look back, do some docs still do house calls? Yeah, but it's not common practice today. Will some docs still do clinical visits only? We'll find out in the future because there will be other options, I guess,
Right. I think that's right.
To support our docs. And as you stated earlier, in this current pay structure we have, there's got to be some things worked out to make this be a success. I'm going to go to Mike's question. Another positive we have learned from the COVID is how we can depress other seasonal illnesses such as influenza when we all practice enhanced hygiene measures. Who knew washing your hands would have made such a complicated solution? How can you speak to this, please? Perhaps some measures can be maintained after COVID.
Yeah, I mean, it's a continuation of the conversation we were just having, isn't it? So let's make a list of all the things that we don't want to give up completely. I'm not saying that I want to wear a mask all the time. I don't. I'm not saying that I want to, see my parents outdoors all the time. I don't. But should we all wear masks on the streetcar in the winter, on the TTC in downtown Toronto at the height of the flu season? Maybe. What is the right kind of middle ground, I guess? And it's the same as the conversation about working from home or virtual care or mask wearing or any of those things. I mean, the only one that I would think we should just keep doing is the hand washing. I see no downside. I see only upside to the hand washing.
Probably should have kept doing that backwards,
Yeah.
From Bob asks, what role do you see, if any, played by the fee-for-service model of healthcare?
Yeah, this is a tough one, right? Because the evidence is pretty clear that there is no good way to pay a doctor. Fee-for-service has all of the perverse incentives that many of you are familiar with. It incentivizes high volume, low acuity care. It doesn't reward dealing with complexity. It doesn't reward relationship building or taking time, which also has a relationship to dealing with what we call multimorbidity, or people who have more than one chronic illness, or people with complex frail elders, or people who don't speak English as a first language, et cetera. And so the more socially complex and medically complex, the less good a system fee-for-service is. On the other hand, the evidence is also clear that physicians who are paid on salary as employees see fewer patients. And in a system where there's already issues around wait times, we may also want to think about what the impact of that could potentially be if we were to move the entire system over. Systems known as pay for performance, which have been tried out both in the UK and actually experiments in Canada and elsewhere, where you're ostensibly paying people for the outcomes of their patients as opposed to the number of people they see, seems to create a perverse incentive for people to not take on patients who won't do what they're told. Suddenly nobody wants to take on smokers. Suddenly nobody wants to take on people with mental illness because they're not rewarded for taking care of patients who don't achieve a certain level of hypertension control. So it turns out actually that every system is designed to get the outcomes that it produces, and there isn't a perfect system. And so although I am not personally a huge fan of fee-for-service, I'm also careful about kind of pinning all of the ails of our system on fee-for-service medicine. We haven't yet found a method of paying physicians that above any assault. And probably the answer is unsatisfyingly that it depends. It depends on whether you're talking about family medicine or specialty medicine. It depends on whether you're talking about a hospital environment or community environment. It depends on whether you're talking about an inner city population with a lot of complexity or whether you're talking about a low acuity, high volume procedural specialty. And it may be actually that different practice models and different populations call for different ways of paying providers. And why should we be surprised that that's the case? Because medicine is a diverse and complex field of work. And it may be that we're going to need to look for slightly more precise definitions of the best way to pay a doctor depending on the circumstances. And that's okay.
Awesome. And the piece on medical environment is that it's always changing as well. There's always an evolving technology there. Our next question comes from Jim, and Jim is stealing my thunder for the closing of tonight, but he says, loved your testimony to the U.S. Congress and senators a few years back. Damn it, Jim. How do we balance hard shutdowns and our failure to date on controlling COVID in Canada?
I'd like to say that I'm not sure that we failed. I think that actually we did a lot of good work across the country in the first wave, and our friends in Atlantic Canada. I was just speaking to a colleague today who's in PEI, and late last week I was on Zoom with a colleague who's in Nova Scotia. I mean, that Atlantic bubble, knock on wood, seems to be holding up remarkably well. So there are lots of success stories actually in our management of COVID-19. And when we look south of the border, not that any of us is particularly, if I may, it's a bit of a low bar to clear, but there are worse case scenarios than the one that we're living in. But we now find ourselves on the cusp of something that looks like it could be really quite serious in some parts of the country, including the place where I find myself right now. And it is scary. I think we're all pretty scared. Should we have locked down in Ontario sooner? I haven't yet seen advice from a public health official that suggests otherwise. We're riding these waves as they come and making decisions as we go. I don't think that a total lockdown of the whole economy for 18 months was likely going to serve people either. I also, as a parent, am a huge believer that kids need to go to school for all kinds of reasons. Some part of the economy and the community need to be opened up for all kinds of important reasons. But we're just going to have to keep flexing to meet the challenge. It's not as though we apply the same solution over and over again. We need to respond to what we're seeing. Certainly in Ontario, I think more restrictions are coming. I certainly hope so, because I don't think that we can handle what the projections suggest. Otherwise, I don't see how we can manage it.
I think you're right, Danielle. And I think from the Alberta perspective, the pieces I'm hearing, our frontline workers were exhausted. They are beyond exhausted. And now the numbers are escalating to a point where I think we all know where we're headed. And I would suggest, for my position, lock it down or do something more than suggest is where we go. I've got two comments here for you. The first one's from Chelsea. This is for all of us online. Just going to have a listen. It says, FYI, Bill C-213, Canadian Pharmacare Act, will be debated tomorrow in second reading at the House of Commons. So I think that it's not quite the act that we would want, but at least it's more than what we have. Perspective on that. And the second piece is a little more in-depth. So any perspective on Bill C-231?
I apologize to the person who posed the question if I'm getting this wrong, but I think this is the private members bill that the NDP is putting forward. And I have not heard there is broad support on every side of the aisle for this act. I confess I've been so underwater in COVID land over these last couple of weeks that I don't know the details of what's being debated in second reading, but I don't think that it's a government bill. I think it's an opposition bill.
Yes.
And maybe it's what we need. I mean, maybe it's what we need to unlock this debate and this conversation. I will take it from any side of the aisle with gratitude if we get there. And it may be that we need a push, not from the governing party, to make it happen.
Beautiful. This next question is going to be one that is not pie in the sky, but it is real and it is down and it's where we are at. And the question is very clear. How do we begin to eliminate systemic racism from our healthcare system?
I don't think you eliminate systemic racism from the healthcare system. You eliminate it from the society and the community at large. You know, systemic racism that people experience as patients and as workers, and those who've been following the horrors of anti-Indigenous racism in our healthcare system and in our country, will know that these things are not unlinked. You know, what happens in a lobster fishery on one side of the country and what happens to an Indigenous woman in an emergency department on the other side of the country, they come from the same place. The work for all of us is the same work, whether we are in healthcare or whether we are in some other sector. I mean, we can put in place mandatory education and we can promote racialized people to positions of power, women to positions of power. We can work to change the balance of power in the programming that we design. Like, there are a million evidence-informed ways that we can work on reducing and eliminating racism, beginning by all of us getting educated and being anti-racist ourselves. Those of us white people who hold positions of power and privilege in our society. I do not think that systemic racism in healthcare is any different from systemic racism anywhere else. It's a reflection of what's happening in the broader culture and the broader society. And so we need to address those issues, not as healthcare workers, but as citizens.
Danielle, thank you so much for your time this evening. In closing, to continue providing events like this and for doing the research that we do, we need your support. It allows us to bring on speakers like Dr. Danielle Martin. Some of the pieces that I picked up on, I would talk about the job loss versus benefit loss is absolutely a piece. When you look at the Pharmacare, dental care, universal basic incomes, these are all pieces that should have been so simple to accomplish in a society that took care of each other. But instead we're confused right now and we're paying for it, I think. And my other word that I've highlighted, it came from you, was to be kind, and you nailed that. And that's in all of this. We have to realize that we're only human and we're only doing the best that we can in a really crappy situation for everybody. So I hope we can pull that together. We'll also be sending out a survey after the conference. We look forward to hearing your feedback from tonight's session. As I mentioned at the beginning, HSAA is a proud provider to support the Parkland conference, so that all of this event tonight and all week has been recorded and will be placed online. Danielle Martin, on behalf of all folks tonight online and Alberta, thank you so much for taking your time to join the Parkland conference. We hope to see you again real soon. And my friends, to all of you online tonight, thank you so much. Support the Parkland, and we'll see you again very soon. Good night.
Thanks, everyone. Good night.